It gives me great pleasure to now introduce my friend and colleague, Dr. Sanjay Basu, who is a professor here at Stanford in the School of Medicine. And rather than taking up his time, I'd rather have you learn about his work. Sanjay.
Thank you. Good afternoon. It's nice to be here, and thanks to those who organized this conference. I've been asked to talk a bit about how machine learning is already being implemented in clinical practice today, and to set up a bit of my approach to discussing this, let me set up the following clinical conundrum. So I'm a primary care provider, and I would argue that supposedly the simplest thing that we treat in primary care is high blood pressure. It's the leading cause of death worldwide now. And supposedly we've studied it for years. We should know how to treat it. It doesn't apparently take any profound expertise. We have a wide array of approaches to treating it. And yet we still, with this seemingly simple question, have a panoply of controversy. Let me pose the simplest question. What blood pressure should you be treated to? Two well-conducted, large, multinational, randomized trials published in the New England Journal of Medicine sought to answer this question. They compared in a simple way whether you should be treated to a systolic blood pressure of 120 or 140. A very nicely simple question. The first study, published in 2010, ended with the following sentence as the final sentence of the abstract. Targeting a systolic blood pressure of less than 120 as compared with less than 140 did not reduce the rate of composite outcome of fatal and non-fatal major cardiovascular events. In other words, heart attacks and strokes. A few years later, another well-conducted, large, randomized, multinational trial sought to answer the same question, and this was the last sentence of the abstract. Targeting a systolic blood pressure of less than 120 as compared with less than 140 resulted in lower rates of fatal and non-fatal major cardiovascular events. So what do? You're a primary care provider, you're seeing a patient in front of you. Do you choose 120 or 140? The guidelines committee that recently resulted in some controversy chose 130 as the average. So here's a dilemma that we face in clinical medicine. It's that oftentimes we see these kinds of figures at the end of well-conducted randomized trials, these forest plots, that are meant to somehow tell us that the effect of a treatment may be better or worse among some subgroup. Chances are that if there's any finding in these plots, they're probably a false positive result. You heard from John Ioannidis earlier about lack of reproducibility. Accompanying that problem is the finding of profound false positives in our research. And from a clinical perspective, I also find these plots terribly difficult to use because people are not one feature. Here it suggests, for example, that people who are older might benefit more from being treated to 120, and people with chronic kidney disease might benefit less. So what do I do with my patient who is older with chronic kidney disease? What we've been doing in practice for the last few years is implementing machine learning algorithms that try to say the following. We know that people are combinations of features. No one person is just old or young and has no other properties as a human. And so instead, can we ask the question differently? Instead of, is it 120 or 140, the question is, who is 120 better for or 140 better for? And is there another number for other people, and why? And instead, often not using the more fancy deep learning methods, but typically tree-based methods, which try to sample from the internal data from the trial and understand combinations of features and then validate repeatedly over time to assess the consistency of the findings, we might be able to explain variations that say, perhaps these trials are not inconsistent. Maybe instead they're just from the same population of people. And being people, we are different and heterogeneous as a population, and some of us may benefit and some of us may be harmed. Can we separate out that variation to know who I should give this more assertive treatment to and who I should maybe avoid giving that assertive treatment to. In one case, for instance, we're able to create a score using these tree-based learning methods that can find the subset of people for whom treating to 120 appears to reduce the risk of cardiovascular disease by about 4% in one of the trials, and meanwhile has no significant benefit for the other groups, while having a substantial degree of harm, serious adverse events. Not talking about the occasional headache, but these are adverse events like ending up on dialysis. And the same score, when applied to the other trial, in fact, was able to still separate out the variation. In fact, even having in the null trial, the ACCORD trial, having a subpopulation that benefited even more. But because the other populations did not benefit, the average result was null. And still, various groups had serious adverse events without having benefit. So here we've separated out the benefit and harm in terms of a multitude of features for the patient that we can describe. And it turns out it's not one factor, age or kidney disease, but a multitude in combinations that are complex that allow us to predict these results. Another way of visualizing this is to plot the probability of benefit on the x-axis and harm on the y-axis. You see that one trial happened to have a positive result for the average, the SPRINT trial, because there's a negative, meaning lower rate of cardiovascular events, while having a distribution of adverse events on the y-axis. The other trial, which had a null effect, the orange trial, had some people benefit and some people not benefit so much in about the same distribution of adverse events. Extending this further, we can ask the question, could we not just compare one arm against the other, but really try to choose the best treatment for our patient when we have a panoply of options? So network meta-analyses are one way in which we can try to gather data across many trials. Here, for example, are treatments for type 2 diabetes, for which there are a large array of options now after first-line metformin, which is typically a good treatment for people without kidney disease. And unfortunately, given the panoply of options we now have for diabetes treatments, severe adverse events from diabetes medications have now become a leading cause of emergency room visits. So we have many more drugs available. Each of them have different benefits and risks for different populations. Some of them even have new side effects we haven't heard of before. For example, euglycemic ketosis is an entirely new phenomenon caused by one of these medications. And as depicted here, we have lots of trials that as a clinician I have trouble keeping track of. Connecting these different medications, the bars show how many trials above the line and how many participants in those trials below the line are compared across all well-conducted diabetes drug trials. It's hard for me to process in my mind as a physician thinking about almost 15,000 patients across 25 trials and saying, for this patient, this combination of features would be helpful for if I prescribe this drug and harmful if I prescribe that drug. Excuse me. So what we've been doing is take the underlying data from those kinds of network meta-analyses to compare all possible drug options and design the risk-benefit score for individual patients, saying here are the outcomes that we have well documented in these high-quality data from trials, which are randomized and therefore not as subject to as many confounding influences as, for instance, electronic medical record data. And we went one step further and said, we know that these trials try to put things in terms of what the medical community paternalistically chooses as the important outcome. All-cause mortality, rate of nephropathy is defined by a laboratory value. But what's important to the patient in front of me? I can come up with a ranking for how likely this medication is to reduce your risk of particular outcomes, but which risks are important to you, and just as importantly, what drug side effects or features are important to you, and let's weight those outcomes by your preferences. Are you willing to inject a medication, or is that such a horrendous idea that you're willing to take some more risk if in exchange it's a pill and not an injection? Pretty reasonable. What about nausea? How about weight gain? What is your drug cost and copay? These kinds of factors in order to rank for you the treatment benefit of different choices, the degree of uncertainty we have, and based on your own preferences, what might be possible to choose amongst or wisest to choose amongst. I, as a clinician, have a hard time doing this in my head, and so using these computational tools may help. We're now doing a randomized trial to compare using this tool to the current standard approach, which is whatever happens, happens. One of the other features that I've been finding particularly useful for machine learning applications is the concept of transportability, which Judea Pearl and colleagues at UCLA first codified in the computer science literature, and which is now, for the first time, making it into the epidemiology literature. The concept is we appropriately criticize trials for having participants who aren't reflective of who we see in practice, right? The SPRINT trial I mentioned earlier and the ACCORD trial had a whole bunch of older adults who didn't have comorbidities. I have no idea where they found these folks, but they're not the folks who are in my clinical practice who have, long lists of diagnostic codes. Can we reweight and balance the sample to understand what the effects may be among a more realistic, nationally representative population? It's not just a matter of reweighting, but also quantifying how much uncertainty you have when you have only a few people represented in a trial and you're trying to extrapolate it into a larger population in the United States. These transportability methods help us understand how little or how much changing the composition of a trial may change the treatment effect. Which is, I think, particularly important when we're trying to translate findings to clinical practice. But it may also help with the problem of whether or not to trust a result. One application of these transportability methods that we've been experimenting with is to kind of check on whether multinational trials or multi-site trials actually have believable data. So, for example, if I transport the result from one site to another, I may be able to explain that people in Minnesota treated with this drug are having different results than people at Stanford site because they're different demographically or in terms of their biomarkers or something else. On the other hand, if I find that those factors are not explaining the variations across sites, I might want to investigate what's happening further. So, for example, we applied this to a heart failure trial, which was multinational, and found that the Russian site, no political commentary there, but it happened to be the Russian site, had profoundly abnormal rates of mortality among the heart failure patients as compared to what would be predicted by transporting the results from all the other sites, and was not really explainable in other ways. Investigations into this trial suggested that the participants were not actually receiving the study drug. There appeared to have been a black market for selling the study drug from the physicians involved. But one of the things that I think is particularly helpful with machine learning in medicine as it relates to the conference theme of inclusion and equity is the issue of how to evaluate interventions for which we can't randomize. Some of the most important changes taking place in healthcare at the systems level. For example, the state of Rhode Island decided to completely change the way it contracted between private insurers and hospitals and healthcare systems, such that insurers couldn't increase beyond the Medicare rate of inflation year on year. And that money had to be redirected into primary care. How do you determine the effect? You can do a before and after, but all of us know that spending continues to increase year upon year. And there's no perfect control group for Rhode Island, right? Many of you are from California. You know there's never a perfect control group for California. So through some matching approaches, we can take the large data that we have now available and say, let's take every individual in Rhode Island affected and find their closest match across features, their history of different diagnoses and treatments, the way that their insurance is structured, their prior utilization and costs, and so on, and create essentially a synthetic control group. In this case, finding that, in fact, the Rhode Island curve appeared to achieve some sort of plateau, which has now been sustained. And interestingly, in this case, showed either a null effect or an improvement in quality depending on the quality measure. And one of the ways that I think using machine learning in medicine is most helpful is when we can start to use data sources that are beyond the electronic medical record. So as many of you are aware, many hospitals and health systems are suffering from drug shortages. We're trying to use machine learning to do proactive prediction of drug shortages. And one of the ways we've also been applying it in California right now is to use the satellite data on smoke and smoke direction from the wildfires to proactively contact central pharmacies for advanced procurement of albuterol and ipratropium, the major drugs to treat asthma and COPD exacerbations, which increase in the context of wildfires. Central pharmacies, understandably, typically use last month's data to purchase this month's drugs. In the context of their systems, it's rare for them to be able to use other sources of information from the broader population in order to anticipate what they need within their supply chain. Analogously, we've also been working to do prediction of refugee streams for aid agencies. Refugee agencies typically use last month's demand for services in order to predict this month's demand. But as we all know, conflict is sporadic and leads to sudden influx or emigration. And in the context of using information from satellite as well as news feeds, we can actually improve dramatically the 1 or 3 month ahead of time prediction of refugee flows in order to allow proactive aid procurement, in this case for Syria and Yemen as well. So overall, what I would argue is that we have strategies available to us such that machine learning can help improve the diversity and personalization with which we approach medicine. But it may take us to move beyond the electronic medical record substantially. I like the idea of using trial data because it helps us with actual treatment effect estimates in the context of a lot of confounding. But I also would argue that we should look more at population data, particularly at social, environmental levels, in order to do the kind of proactive prediction on social determinants of health that we often omit from our clinical practice. I'll end there and thank the many people who have worked with this data and produced the results that I presented here. Thanks.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.